how long do you typically see it take to really get some traction with improving symptoms?
For me, that's 1 month, right? Now, that may not be enough to totally, eradicate everything forever, but to me, just in general, if people are following what I think is a good comprehensive protocol, and in a month, they're showing improvement, that's even more convincing. But if there's absolutely no change in a month, then I'm going to think one of two things. One, I missed it. They don't have it. We need to move on to another, try to figure something else out. Or two, the protocol I created is not strong enough, and we need to try it once more with stronger antifungals, and move forward in that regard for one more month.
Dr. Mona Morstein, welcome back to the show.
Thank you, Dr. Ruscio.
We have had conversations back and forth. Well, firstly, let me say this again, because you were on the podcast a number of years ago, and you were one of the first people that really opened my mind to naturopathic medicine, natural medicine. It was sort of early in my career when I was in college. I was pre-med, and I, like many, I think, healthcare or future healthcare providers, I was trying to figure out what way do I want to go. So I shadowed a few conventional doctors, and it wasn't quite what I thought it was going to be. With no offense, right? But it felt, it wasn't the Grey's Anatomy that I thought, where there would be like a lot of time, a lot of thought. It was much more so, shorter visits, the whole model, which is fine, all and good. That's what it is. But I saw one of your lectures at a naturopathic medical school in Arizona, and I remember thinking, almost like getting struck by Cupid's bow academically. I was like, this is it. Like, this is totally what resonates with me. The way you were thinking and making your argument and talking about the natural medicines. So I want to thank you firstly for that, because that was a pretty cathartic, like eye-opening observation for me. And I think you've been doing amazing work all your career. One of the areas in which I think you have brought some very interesting information to the table is on fungal overgrowth. And that's what we're going to dive into today.
Fantastic. And really, I'm really honored. Thank you very much. It's a really great anecdote. I didn't know that. And thank you for taking a moment to share it.
Absolutely. Yeah, no, I mean, I think it's important that people in the alternative space carry that torch so that young, eager minds see the options. And I had not really a good clue about the other side of the world. And so again, thank you. That was really helpful. In this other side of the world, alternative medicine, something that comes up a decent amount is fungal overgrowth. We've talked about this on the podcast a lot. Maybe one of the things we can start with, maybe even taking a step back, how did this first come onto your radar? Was it something that in your education, it was really well laid out? Did you find your way to it clinically? How did you get more involved in this?
Well, I've been in practice 36 years, so started practicing around 1989. And right around the 1990s is when our country underwent this fat fear decade of fat is bad eating. And so people were turning to carbohydrates and fairly indiscriminately. And so during that decade, which was really my first full decade of practice, from the beginning to the end, I just saw so many people having fungal overgrowth problems, whether it was just more visibly through vaginal and overgrowth on the skin, the feet, the toes, or so much gut overgrowth was happening. And it was, I think, really started to dawn on me during that low-fat, high-carb decade.
Yep, that makes complete sense, which is one of the risk factors for fungal overgrowth is a high-carb consumption. And I think we're on the same page, but maybe correct me if I'm wrong, that we're kind of dietarily agnostic. It's just more so about finding what's going to fit for the person. Because at least I see some people who thrive on, let's say, keto, and then some people who really do not do well on that sort of dietary plan, whereas others do better on a moderate to higher carb diet. Of course, all of this is within the framework of no processed foods or really minimal, and I should say ultra processed foods, because some processing is fine, but avoiding the junk essentially, right? And opting for whole fresh foods.
Right. I mean, I think one of the beautiful things, I hope, with integrative medicine, naturopathic medicine, is really working with each individual. I do not believe there is one diet everybody should eat. Like, I mean, I have a book on diabetes, but no, everybody should not live low carb. Like, that isn't what everybody needs to do. And in fact, healthy carbs, your beans, your whole grains, your veggies, fruit in moderation, like that's not going to cause yeast, right? That isn't going to grow yeast. So I definitely agree that what you're saying, that we have to look at each patient, who they are, also what their medical condition is, because obviously diet has to be merged to work at eradicating what they're struggling with, and then do that specifically.
And by the way, if this has been helpful, please comment and subscribe. This really does help us reach more people who are trying to improve their health. So it is quite deeply appreciated. Let's talk about some of the symptoms, because one of the things I'm starting to think and observe is that while any GI condition can manifest outside of the gut, so neurologically, with the skin, with the joints, maybe fungus is more likely to cause neurological symptoms like brain fog and fatigue. Again, there's overlap, but if I'm seeing really pronounced fatigue and brain fog, I think more fungal overgrowth than bacterial overgrowth. It could be both, but I lean more in that suspicion of etiology. Do you find the same general thing?
100%. I mean, if we look at, say, bacterial, either in the colon, Klebsiella, Citrobacter, Proteus, whatever. I mean, that may be my ignorance. Like, they're not really outputting a lot of toxins. They're problematic to the gut when they're overgrowing in the gut. And also SIBO. I mean, SIBO, they're producing hydrogen and methane, but with fungus, I mean, we have clear irritants that it produces, and and like acetaldehyde, brain fog, right? So for me, if they've got gas, bloating, and brain fog, like, my mind has already gone. You have to prove to me you don't have fungal overgrowth. And this is especially in patients, say, who have been, say, successfully treated for SIBO and still have these symptoms going on. So, those two alone, and of course, like you said, there are other ways the symptomatology can continue to proliferate, such as fatigue, a lot of muscle aches. Like, I've had patients that couldn't exercise because when they exercise, it feels like their body comes down with the flu. And when we diagnosed and treated their fungal overgrowth, they could exercise like they were 20 again. So it can go I see it a lot with interstitial cystitis, right? Because it can be a clear symptom in the bladder. Of course, headaches, of course, and other yeast overgrowing on the body. So it can really play out all throughout the system.
And the exercise intolerance, is this due to metabolism of acetaldehyde? Is that, or what do you think the mechanism is that underlies
So
that?
it's interesting. If we have the acetaldehyde, and but then we have tartaric acid and oxalic acid and arabinose and subbaric acid. Like, there are other toxins that are made within the yeast cell that can be um, absorbed systemically if the gut is not that healthy. Particularly, it's certainly an indication of intestinal permeability if we're getting systemic symptomatology from the intestinal fungal overgrowth. So, I think that, I mean, oxalic acid, if we just look at that has irritations also all throughout the body.
let's linger here for a little bit because this is something that I feel is pretty interesting in the sense that it seems that fungus produces more metabolites and toxins than does bacteria. Acetaldehyde, propionic acid, ammonia, uric acid, oxalic acid. And I mean, there's so many things here that tie into limitations of energy production. I mean, with acetaldehyde, that can lead to nutrient deficiencies similar to excessive alcohol consumption by depleting vitamin B1, thiamine, vitamin B2, vitamin C, amongst others. And so I especially think about how common overconsumption of alcohol is in our society. And I'm not saying no alcohol is what we should be aiming for. I do think if someone, oftentimes looking at this in sort of a rehab plan, if someone goes to rehab, fixes their musculoskeletal problem or their gut problem, they can resume healthy activity or they can resume things like a moderate amount of alcohol. But nevertheless, I wonder, and I can't help but think, how many people are coming from a place where there was a period of too high of carb consumption, probably some stress, and then alcohol consumption. If there's a coexisting fungal overgrowth, this is going to utilize a lot of the vitamins that are necessary to metabolize the alcohol because all these other things also feed fungal overgrowth. So yeah, I mean, do you want to say any more about these
Yeah,
metabolites?
I mean, for sure, I think even iron, molybdenum, NADH, yeah, you're right. Aside from the other nutrients you mentioned, uh, these are all involved in that breakdown. I don't know. I've had patients that go on vacation and I don't know why people go on vacation and just think, let's just be drunk every day. I don't get that. Like that's not my vacation plans, but that is a lot of people's vacation plans. And just came back with a raving fungal infection, right, that has been chronic until I saw them and thought about treating them that way. Now, I think if you've got fungus and we're trying to you're using nutrients a lot in those detoxification aspects. That's draining out of people more than we want, right? Um, so I mean, that's also, I mean, like my general treatment for all of my patients, every single one, is to always put all of them on a good multiple vitamin. Like I just think this has to be put back in so that at least they have every vitamin and every mineral that they need to potentially get healthy and then to stay healthy. And I'll do that with my fungal patients too, instead of nitpicking, just the ones you've mentioned. But we just have to give these people all the support they need to
Yep.
recover their health.
I agree. And, there was a little while where I sort of leaned away from multivitamins. Kind of the purist in me was, well, maybe a whole food multivitamin, but I just don't think we're going to have the absorption and the dose needed. Now, it's different, right? We're not talking about long term when you're healthy. What do we do for maintenance? We're talking about someone, again, needs sort of rehab, if you will. How do we get them out of that position where they're probably depleted? And this is where I think a full dose clinical multivitamin. And for people watching this, I know that sometimes that means taking 3 capsules twice per day of a multi, and it seems like a lot. But what I say at the clinic is look on the back of the bottle. Look at the 20 some odd nutrients you're getting. To expect to get a clinical dose of all of those in one pill, it's just not practical. So this is why I've really sort of encouraged people like, hey, don't skimp on the multi. Make sure you take the full recommended dose because I'm with you. I think we really want to just replete somewhat aggressively to help offset some of this.
Yeah, at least a full dose for, say, a couple of months, right?
Right.
To allow healing, regeneration, and then say lower it to maybe the 3 a day, for longer term. But we're on the same page, 100%.
Let's talk more about some symptoms. We mentioned brain fog and fatigue, so certainly making a flag for our audience about those. Constipation and diarrhea.
Yeah.
Do you see one of those more often than the other?
Yeah, I totally see constipation a lot more. And I'm expecting constipation. I was at a lecture where another doc was talking about fungus and said diarrhea, and I don't see that. I don't see that that's any kind of common gut response with their bowel movements, but the constipation, to me, that's 99 out of 100 patients are more on that side. But I know some other docs have different patient bowel movement presentations.
Gotcha. The muscle soreness and muscle pain also, I'm assuming, and joint pain.
Yeah.
What's interesting here is a lot of this sounds like Lyme disease or a vector-borne infection, the more contemporary term. And I know that some in the Lyme community will comment that if you're seeing non-responsiveness to the Lyme therapeutics, think fungus. Are you ever seeing, the vector-borne infection of some sort
Well,
entangled with
actually,
fungus?
I was just at our state association. I'm on the board of the Arizona Association, Naturopathic Medical Association. We just had our yearly conference last weekend, and two of the big lectures were on Lyme. And I remember Dr. Mitchell saying that especially it's wandering, migrating joint pain. That's really the keynote. And so with my fungal patients, I don't tend to see that. It tends to be more common and stable in the areas of presentation versus wandering or migrating around. So if I so I imagine Lyme could be involved in some patients, but generally most of those most patients will respond to the fungal protocol, especially if they're stable joints and stable muscles that they're presenting discomfort with.
Cravings, sugar cravings. This is something that, I've been trying to describe this to people in a way because sometimes when we describe cravings, people are picturing severe cravings and they're not queuing in on if after dinner, and given it's a, ample dinner, you didn't have like, 2 ounces of food, you're
Right.
still craving chips or rice or chocolate. That's an indication. It's not a guarantee, but I think people aren't queuing in enough on if they don't feel satiated from a normal amount of food, or if they're struggling with, I'm trying to eat less, but at the end of the night, I still need to snack or have a little extra. I think that's a flag that people should be more cued into because, at least in my experience clinically, when you start addressing fungus, either dietarily or with herbals or probiotics or whatever, their cravings diminish remarkably. And people no longer have that thing where they feel they're fighting off the urge for a slice of bread or for a piece of chocolate or what have you. Okay, so in case we look a little bit different, we had a tech glitch, and this is part 2 of the recording a few weeks later. But picking up from where we left off, where we lost internet, I was asking about from the Santelman paper. He did this really cool analysis where he found 7 symptoms were predictive of if people would respond to antifungal treatment. One of the symptoms that kind of caught my eye, I guess no pun intended there, but there's a little bit of pun, is eyes that are itchy, watery, as a potential clue of fungal overgrowth. And so where we left off was I was asking you, is this something that you've seen much of?
So no, I haven't seen much of. Now, people who have an overgrowth of fungus can have sensitivity to odors, be more susceptible for allergies or toxins, getting more susceptible to environmental toxins. But honestly, I'm not sure where he came to that, but I would say that's never on my radar and has never been, and I know never is a strong word, but I can't ever recall someone bringing that in as a main symptom, nor would it necessarily, excuse me, be a main symptom. I'd think, oh, that's got to be fungal overgrowth versus some other allergic component.
And I don't think people complain about that a lot. And maybe one of those things that's just, if you've got 10 symptoms, that might be the least problematic one. And so you kind of focus as a patient on reporting the symptoms that are the most annoying and problematic to you. But in any case,
I mean, it's true.
maybe
Like I went to a lecture on someone on fungus who said, oh, they have diarrhea, which I've never seen, so, my patients are constipated. So I think how patients presents, maybe it's locality, maybe it's just what you attract, or I honestly believe there could be definite symptoms that one doctor has where there's very different symptoms that another has that can
sure.
lead to the same diagnosis.
And that's sort of what I've seen is more of a, I think anyway, more of a diarrheal presentation. But to your point, I don't think anyone has, these things so pinpoint, determined. One of the things that we can use to help determine if a fungal overgrowth is present is testing. I was having a conversation with a family member recently, and it's interesting that the paradigm, I think, amongst the public can be that the testing will tell you everything. And I've kind of been harping on this for a while, so pardon to the audience if this seems sort of trite, but as great as the testing is, and I think it's getting better every year, I'm still not convinced that we can do a workup and have a high level of accuracy for fungus. We can get some clues, but I think there's things that we miss. Now, maybe we can go really comprehensive and we can do feces, we can do antibodies, we can do urinary organic acids. That's like $1,000, and it's a lot to ask the patient. They got to do a blood draw, they got to do a fecal sample, they have to do a urinalysis. But there's options here. I'd love for you to sort of expand upon the tests that are available and what you feel, the merits or drawbacks of these tests are.
Right. Just starting off with ones you said, a stool analysis will can potentially identify fungal overgrowth only in the colon, right? Because as we know, stool has zero to do with the microbiome in the small intestine, right? So if it's a PCR testing or if it's culture, if they are picking up fungal overgrowth, we would have potentially a decent idea if it's matching the patient presentation that it's overgrown in the colon. The problem is with the small intestine. This is why I always combine a stool test with the comprehensive Candida questionnaire, the 2-page one from Crook's book. And if the colon is negative and the fungal questionnaire is positive and the patient presents with symptoms, then yes, you're correct. It's an extrapolation that there's SIFO. And really right now, I tell patients, we've got rover on Mars, analyzing the metals in Mars dirt, and we don't have a good test for the 20 feet of fungal overgrowth in the intestine,
Right.
in the small
Yeah.
intestine,
Well
right?
said. Well said.
There are technology gaps in what people can do. So SIFO is oftentimes, for sure, an educated extrapolation. Now, the OAT test, right, is, the OAT test was, invented 30 years ago, mainly for the kids on the autistic spectrum, right, to mostly analyze fungus, C. diff, which are overgrown in the ASD kids, and just genetic metabolic abnormalities to help understand that population. Now it's expanded somehow to adults and neuro normal patients.
Hmm.
For fungus, they're looking at urine tests such as tartaric acid, arabinose, just factors that are produced by fungus in the gut and can wind up in the urine. So we're trying to now. Is it small intestine or colon? Of course, we wouldn't really have an idea in that regard. The antibodies, obviously, if the
Oh, sorry,
IgG
Mona.
antibodies aren't necessary.
Let's linger
Oh,
just for 1 second on the organic
okay,
acids. So,
sure.
do you find those to be fairly, correlative to presentation? I know Jeffrey Moss had this, he had done a great clinical training on organic acids, and sort of the too long done read there was organic acids are an early screening tool. They've got to be confirmed with something that's more diagnostic. That was at least his perspective.
Yeah.
Do you look at organic acids for fungus the same way?
I never do organic acid,
Okay.
so
Well, that tells us a lot. Okay.
so it's not a test that I run with patients. So if I'm going to start with a test, I mean the main way I do it is stool with the questionnaire, right? That's going to be my with patient presentation. Those will be the two ways that I like personally to work with patients. So I just personally don't see a lot of benefit myself from, and I know there are many different ways to interpret it. I've done they have, you can look at their lectures and their booklets and on how to interpret it for people that are not autistic spectrum, but I just have never found it to be necessary very often for my analysis of patients.
Okay. And I think it's important just to underscore what you said, which is lab tests are accurate in the cohort they were validated. And we can use them beyond that. We don't need to be like ultra rigid, but it's much more inferential. And that's why I come back to what I said earlier, which is I can't too confidently hang my hat on any one of these markers.
Yeah, I mean, honestly, if I do a stool test and the yeast is really overgrown and they've got what's presenting to me the fungal symptoms that made me want to do this test, like I'm convinced I'm good, right? I am. But like you say, that's colon. And SIFO is a pretty big problem. I mean, if we know Dr. Rao, he's saying 40% of SIBO patients have SIFO. And that's the one that's really hard to understand if you really have it or not. It's definitely extrapolation,
Yep.
right?
Yep. And so you were saying with the antibodies, and
Oh,
who
with
is
the
it?
antibodies, obviously, the problems, of course, with IgG is that is past history. They could have had it when they were 10 and not have it now. So getting an IgM, obviously, there's also IgA, but IgM at least is saying right now there seems to be an acute problem with fungal overgrowth antibody. So, I don't really IgG is just a problematic antibody in this regard, right? So if you don't have it really matching IgM, to say that right now it's a problem is difficult. Just like unless you get, for example, a positive early antigen with Epstein-Barr, IgG Epstein-Barr isn't going to tell you anything, right? It's going to be high because nearly every human on the planet has had it. So the same for me with just wanting to see IgM to really say it's a current problem now.
And also with the antibodies, there's more than just Candida albicans. There's a
Right.
number of different species,
Exactly.
only part of which we can assess via an antibody assay. So, I want to keep bringing the audience back to this because I always think about the person who's struggling, and I'm sure you've had the same thing. They say to you, Doc, I'll do whatever it takes, thinking that if they're just willing to put a bunch of money on the table, that's going to give us this really definitive diagnostic capability. And we can get some, yes, but at the end of the day, and I think we're on the same page here, if we see multiple symptoms indicative of a fungal overgrowth, especially if their lived experiences, oh boy, let's say they did a SIBO breath test and they had a lot of brain fog after doing that 2 days of just meat and rice. It's pretty indicative of someone who's got a fungal overgrowth, right? So I think those are the cues that are probably the most representative of
I
what's
mean,
going on in the gut.
100%, because LabCorp or SonoraQuest, they're not doing antibodies for geotrichum and rhodotorula, and these are very common fungal overgrowths. Everybody just thinks of Candida and
Right.
Candida albicans, but there's glabrata, there's Paracephalus, there's so many different Candida species, and then there's just as problematic other species of fungus, that could easily be missed, at least for sure with the blood work.
Sure. And then not to not to get too into the weeds here, but if someone has had enough stress, potentially some sort of other infection, it's possible that they may not have a very robust antibody response. This is something I was just going through one of the iLabs training courses, and Joe Burrascano does really great work over there. And one of the points he was making is that if you're in mid to late stage infection, you may not have a very robust antibody response. And so you may see direct measures of infection in the body high because there's a lot of them. But that's due to the fact that the immune system is suppressed and there's not a lot of antibodies being produced. So, again, not to like go too deep into the weeds, but like you said, antibodies, they can be helpful, but they're certainly not a perfect test.
No, not in any way, shape, or form.
Yeah. So then you're doing the stool test plus the questionnaire, and that's how you're making the diagnosis, so to speak.
That's with with people that are presenting with the key symptomatology. That's making me think along those ways.
Right. Right. Okay. Let's get into treatment now. Maybe we start with an overview. How long do you typically see it take to really get some traction with improving symptoms? General. I mean, it's going to vary,
honestly,
I know, but
yeah. For me, that's 1 month, right? Now that may not be enough to totally, eradicate everything forever, but to me, just in general, if people are following what I think is a good comprehensive protocol, and in a month, they're showing improvement, that's even more convincing. But if there's absolutely no change in a month, then I'm going to think one of two things. One, I missed it. They don't have it. We need to move on to another, try to figure something else out. Or two, the protocol I created is not strong enough, and we need to try it once more with stronger antifungals,
right.
and move forward in that regard for one more month, right?
Sure. And that tracks with my experience. I often say at the clinic, give us 2 or 3 at bats, give us 2 or 3 attempts. And if we're not able to get any traction in the GI after 2 or 3 attempts, or at least within the one subset of an issue in the GI we're trying to address, fungus, if we're not getting movement after 2 or 3 attempts, then we're probably barking up the wrong tree. We've probably missed something. And then I think you have this overview of you have a month on the diet plus antimicrobials. And then the second month you start
No,
opening
no.
up the,
Well, I mean,
please.
antimicrobials plus the biofilm buster and plus a probiotic.
Okay. Okay. So
So
a
those
fairly
are just all,
comprehensive.
all three together.
Yep. All right. So diet, antifungals, biofilm, probiotics, month 1. Month 2, you're going to start opening up the diet, which
Well,
also
this is for
totally
people that have had when
responding.
they come back, and
Yeah.
it's just been so successful,
Right.
they're feeling so much better. They're having normal bowel movements. They don't really have the bloating. They've lost some weight, which can be held with the fungal overgrowth. And yeah, then I do feel we can open up. Yes, then I do open up the diet, generally maintain the medication, the supplements, but I might reduce one or so, but generally keep that program pretty stable. And and then for another month or so. So yeah, you're correct.
Yeah.
Yes.
And pretty much tracking with my experience, which is as soon as someone's seeing suitable improvement, that's when we start opening up the diet a little bit. And I think that's mainly just because we don't want people to be eating their way into nutrient deficiencies, 1. And then 2, it can be challenging, and we don't want people to start to develop this unhealthy relationship and perspective with food. Now, maybe it takes someone a second or a third month until they get to a point where they have a satisfactory level of improvement. But it shouldn't be, in my view, 6, 8, 12 months until we hit that
Yeah.
point.
Oh, no, not at all. I mean, and also look, integrative medicine, I mean, where, patients are paying out of pocket, it's very rare. I have somebody not improving at all for 6 months, and saying, okay, yeah, let's just keep going. Like, I mean, generally, people should expect, and I would like to help them attain, improvement sooner to, keep them coming and keep
Yeah.
them feeling it's a justifiable expense.
And, I keep drawing in this parallel to Lyme disease and vector-borne infections because we've been doing more with this in the clinic. And what's been so interesting and why I keep tying this in is it doesn't follow the same time trajectory as gut care. It's almost like in gut, we're kind of spoiled because there's a fairly quick time to response. And it's not to say that won't happen with treating Lyme or Borrelia or Babesia, but I think because some of those organisms can be so directly immunosuppressive, it can be a longer time course because you really have to wade through getting the infection level down enough to stop the immunosuppression. And it's like, as you start doing that, then the battle kind of begins. So it may be a few months until you get to a point where the immune system can kind of come back online. So it can be a longer time course. And the reason why, again, I loop that in is if people have been competently treated for a fungal overgrowth and they're 2, 3, 4 months in and they're not really responding, it might be time to pivot the differential diagnosis, so to speak, and look at something else. And just trying to warn people about that because I know we both see the people who they might be 2 years into just thinking and beating the drum of it's fungus, fungus, fungus. And that doesn't seem to be the way that these GI conditions play out for the most part. They're fairly fast to respond.
Yeah, and to be honest, I generally get people who have never been treated by fungus. They've been SIBO'd up the wazoo,
Right.
and they still have bloating. They still like people have never. It's never been brought up. It's never been addressed. I would say that's my much more common patient than ones who have really had someone open up their eyes to the potential of a fungal overgrowth, right? And have been on a protocol for that for a long time.
Yeah, well said. And this is why one of the screenings we're implementing at the clinic out of the gate is trying to quantify or identify if someone's a bacterial overgrowth versus a fungal overgrowth. Because in some cases, what you see is there's a lot of interest on the behalf of the patient in prior treatment history for SIBO, small intestinal bacterial overgrowth, but there's a lot of symptoms of fungal overgrowth that haven't been addressed.
Totally, 100%. I agree 100%. Yes.
Let's talk because there's a lot here for us to unpack, but with diet, I think one could go all the way to keto, really low carb, and that would be fine for some people, right? And I think time and place, maybe if someone's overweight, they have been eating a lot of carbs historically, keto might be a good pivot for them. Now, if someone's not overweight, maybe they're a little bit more on the underweight-ish side of the spectrum, we would want to be a touch more selective with weeding out the high impact processed, really sugary, starchy carbohydrates, but not limiting everything and keeping some of those fruits and starches and things like that that are lower glycemic index, lower glycemic load. But I'd love to hear more about sort of what the diet looks like in terms of, how you're personalizing this to people. Because we know that carbs are going to be a big problem. Carbs is a broad term. Within carbs, it's not going to be the FODMAPs and the prebiotics like it is for small intestinal bacterial overgrowth. It's going to be the sugars and the starches. But yeah, how do you look at the nuance of this application?
I would say probably if people looked at my diet, they'd say it's a little looser maybe than, if you go online, what's a Candida diet? Um, oils are fine. I do allow grains, but they have to be gluten-free, whole grain, sugar-free, and yeast-free. And so I have so people can have brown rice or brown rice pasta or quinoa or oatmeal. I don't see that any of that really winds up being a problem for me. I don't let them have fruit for 2 weeks, and then they can have one fruit a day, but not a banana. And then other foods in the fruit, tomatoes, cucumbers, olives, avocado, coconut, those I don't really care about, right? Fruit, veggies are fine, but for mushrooms and white potatoes, um, and I avoid peanuts and pistachios. Probably one of the biggest things I avoid is vinegar with patients. They can have lemon juice and lime juice. Of course, with beverages, they can have water or fizzy water if they want, any tea, unsweetened alternative milk, and coffee substitutes. I do pull out coffee because I think it's hard to heal a gut with all the acidity of coffee. And if that's a deal breaker, they just can't do it. Then I'll recommend low acid or no acid coffees, right? Just to have it be a successful protocol. And then obviously avoiding the refined sugars, right? And also dried fruit juices, the concentrated. I do let them have stevia and monk fruit and xylitol. Avoid antibiotics. They avoid alcohol. Um, and that's kind of what I've been doing for 36 years. And why it gives people it gives people proteins are fine, just anything they want aside from the peanuts and pistachios, except we go over you can't have these fish because they're toxic, or the grass-fed, grass-finished, meat and the details. You don't have to go into here. You would understand, just going over how to eat healthily. But that's my diet. It's not as strict as ones that are online. I don't think you have to avoid whole grains. And that's how I have people eat.
And you're making I think you're making anyway. Let me know if you agree or not. But a point that you don't have to nail the diet doesn't have to be perfect in order to get in response. And this is one of the things that's always an issue. And I get it with patients, but every once in a while we get a follow up from someone after their initial treatment plan, and it's just like 17 questions about different foods, super in the minutia. And the thing that we always say, but it just is worth repeating, is that those small nuances. Like I looked up this one Candida diet and it's different than the other one, and so I'm not sure what to do, and it's like this paralyzing fear. Yeah, and so what I think we'd want people to know is those things don't matter. What matters are the things that are the biggest rocks, the most impactful issues from the diet, plus the herbals, plus the biofilm agents, plus the probiotics. And that's going to work. And if it doesn't work, it's not because you followed the wrong iteration of the Candida diet and you had, the wrong type of whole grain bread or whatever it is. It's, if it's not working, we're probably treating the wrong thing. And it can just alleviate so much stress, I think, for people if they understand that concept.
Yeah, I agree. I've had also patients email back, what about this? What about that? What about
The
these
whatabouts. Yeah, we call
foods?
them the whatabouts. Yeah.
Yeah, the whatabouts, right? Yeah, exactly. So you're right. And honestly, two of the breads so I have a set of 4 breads that fit this diet because people like to have bread. When we're done with the whole handout is like 6 pages. And when we're done with that, I go back and I say, you're going to see in this bread, there's like a tablespoon of vinegar in it, but that's for the whole loaf. It's fine.
Yes,
And
great
in this
point.
bread, there's like a tablespoon of raisin juice for the whole loaf. It's fine.
Yep.
Don't worry. I know about it. It's not going to ruin everything. So
So
just
important. I mean,
don't
so
worry.
important, because this is one of
It's
the
true.
things that again, I just see people really spinning their wheels with, is that they get down into the umpteenth level of minutia. And, again, just want to say for people that isn't going to matter, and don't make your life a living hell, because it's impossible to get to absolute zero with Candida, with FODMAP, with histamine, with any of these things. It's just about generally reducing your load by 70, 80%, let's say, roughly speaking.
Yeah, I think alcohol, sugar, like those cause fungal overgrowth, right? If you just ate a meal out and you saw there were some mushrooms in it, no, we don't have to start again from
Right.
scratch, you know?
Right. Right.
I
Right.
agree. But you know what? I think you're right that I think that the the orthorexia, this neurosis of eating is unfortunately a side effect of many of us physicians working with patients, and that this doc says you have to avoid this, these say you have to avoid this, and they're watching all these lectures, and it can prey on their minds, to really make them very anxious
Yep.
about what they're constantly eating.
Yep. Which is why I always say that people, lay people should be careful not to follow the advice of people or be very selective with following the advice of people that seem to have this really assured, strict, extreme perspective, because usually those people are either not seeing patients, and oftentimes doctors, they want to look like, if I'm just being totally candid here, they want to look like they're still treating patients. And if you fact check some of these things, some of the gurus haven't seen patients in 5, 10, 15, 20 years, but they'll say, I find with patients, and they're referring back to 10 years ago, A, or B, they may only be seeing the people who are on the bandwagon, are responding to what they're doing, and they kind of get that, well, if it's not working for you, go away, or you're doing it wrong, or you're the problem. Any clinician, in my view, who's working with people and listening is gonna see these rules apply, right? You don't have to be perfect. There's no need to be strict. There's no need to be extreme or absolute, and not everything works for everyone. So we'll give a hypothesis therapeutic trial, and if it's not working, then we're going to pivot. But it's not going to be, well, we've got a double, triple, quadruple down on gluten-free, on Candida, on histamine, on whatever it is. And I think if people can internalize that, it's going to save them so much struggling and stress.
I completely agree, and I think that also goes for any clinician that has one diet that all people should be following, right? There's just no way with the individuality of people and their health and their genetics and their culture, and that I think the most beautiful part about integrative medicine is finding the diet that each individual needs to have their health be ideal, right? But not believing there's one for all, right?
While we're on diet, and fully agree, um, there's some overlap between Candida, the Candida diet, and histamine. The sense I'm getting is people with fungal overgrowth might be more likely to be histamine sensitive. Some of that's going to be weeded out in the Candida diet anyway, with some of what you mentioned, alcohol, right, yeasts. But any special preference or integration of histamine rules, or how do you think about histamine if it pertains at all to fungal overgrowth?
Um, I'm not going to incorporate them together to start with, right? If a person, with histamine, I certainly would be wanting to see just more food reactions along those lines. Not that I get brain fog, but I'm flushing, my nose is running, I'm allergic, there's more abdominal pain, and a little more what I would categorize for me, a little more histamine type of food reaction. So I think the fungal diet is really a lot for people just as it
As it
is,
is.
that protocol. So let's just do that for the month and, see what happens and
Yep.
then make adjustments as needed from there.
Yeah, seems very practical.
I would
Um,
say that's a good adjective for my medicine, for my practice.
and it has to be. I mean, because if not, like I said, you can just really tie yourself into knots pretty quickly.
Yeah.
Probiotics, are there any in particular that you think are more effective for fungal overgrowth?
I don't, so my probiotics kind of split between, have you recently had SIBO? Because then I'd like to give a probiotic that I have found really doesn't affect the SIBO gut. And if not, then I'll use a different product. these are just products I've been using a long term. And I use, I like the Claire Therabiotic Complete powder or capsule. But the powder is great because it's so strong and financially, people could take, an eighth of a teaspoon and be getting 50 billion, and the bottle lasts for 4 months. And it's just financially a really strong, cost effective way of getting good levels of probiotics in the gut. And then I like Lactoprime Plus from Claire, or well, that's, I guess, my main SIBO one. There's another one from Zymogen, the ProBiomax DF brand, as well. So I find that those are very well tolerated with SIBO patients. So that's kind of how I split probiotics.
Are you liking something like a soil-based probiotic? So for the audience, I would classify those probiotics generally as blends of lactobacillus and bifidobacterium. There might be some strep thermophilus in one of those, but generally a lactobif blend. Saccharomyces boulardii, some of the soil-based probiotics. Are you integrating
Mm-hmm.
either of these?
So innately, I don't, use the soil-based ones. Um, um, so I honestly, I know it sounds weird, but Saccharomyces boulardii being a fungus, I kind of avoid at least in the first month. The other plant-based ones, the blends and so forth, I don't want to sound. I just really have not had good success with them that I could note adding them into a protocol made a difference much. And I know I may be standing out that way. That many other physicians have had good, reactions with them and noticeable improvement. I can't honestly say that's been my experience. So I tend to go more with the lactobacillus type bifido blends
Sure.
first, just to see how they're working.
Okay. Something I've been thinking a lot about in the context of fungal overgrowth is the importance of prebiotics, fiber, maybe resistant starch. Different for SIBO, certainly out of the gate with small intestinal bacterial overgrowth. If we've qualified this, always wanting to be careful to fact check because someone might just think it's SIBO based upon what they've read or been told, and that might be incorrect. So we want to be careful not to carry over incorrect prior diagnoses into someone's treatment plan going forward. But this is the cohort, the fungal overgrowth, where I really think we want to be using prebiotics, fiber, resistant starch, because we want to feed the native commensal bacteria to help police out the fungus. One of the things that I think we want to really give people a heads up about is it's somewhat common the first maybe week or so to have some gas, some belching, some flatulence, maybe some looser bowels as the body's acclimating. This has been, well documented in the research studies that give prebiotics is that, there's that adjustment period. It's important and worth mentioning because people might say, oh my goodness, this is irritating my gut. I got to stop. As long as you're not getting, in my view here, alarm signs, as long as your intuition isn't saying, oh my God, something's wrong or broken, and you're just noticing, yeah, my bowels are a little bit looser, or I'm a little bit gassy, I'm farting, I feel a little bit bloated, give that a week, maybe a week and a half, or just back the dose off, give it a few days, and then ramp back up a little bit. That can circumvent some of the turbulence. I haven't seen a lot published here, but as we've been experimenting, it does seem that this group of people really stands to benefit from the prebiotics, from the fiber. And why I think this, again, is maybe worth underscoring is I've been critical of prebiotics for SIBO and for IBS. And there's one fairly keystone meta-analysis that was published, I think, just last year, looking at prebiotics for irritable bowel syndrome and finding no benefit. But that's probably more your gut brain SIBO and not fungal overgrowth. So this is somewhere where I do think these tools have a lot of merit. Curious what your experience is.
Yeah, absolutely. Honestly, when I do stool testing with anybody who I do stool testing with, there's a significant depletion of beneficial bacteria. And I'm going to extrapolate in the vast majority of people from, I mean, I'm a naturopathic physician and I've had antibiotics probably, maybe 8 times, 9 times in my life. I mean, it's just something that has happened, right? And aside from potentially not always eating perfectly or whatever, stresses, etc. So I tend to like to do the eradication first. So eradicate SIBO or eradicate the fungus and then spend the 6 months or the year rebuilding, the microbiome with prebiotics to get the gut microbiome solidified and much more reestablished as normal, which can prevent fungal overgrowth again, right? So you're right. As I was taught, when you have a depleted beneficial bacteria in your microbiome, when you first put the prebiotics in, a lot of the other bugs that you don't want, like Klebsiellas or these, they're going to start eating it. And then it's going to be feeding your beneficial bacteria, but they're going to take a little bit of time to build up, and kind of squash the ones that can cause the symptoms and then settle them down, right? So I exactly was taught that honestly it could take even up to 2 or 3 weeks to have that kind of a turnover, that the Benny, as I call them, the Benny bees, are enough to squash the bugs that were just eating it to begin with, and now they're growing. They don't make that kind of gas, and they're reestablishing, beneficial control in
Sure.
in the microbiome. So, 100%, I agree with what you were just saying.
And also to your point, maybe you're bringing Rao's research back in that people can have both fungal and bacterial overgrowth. If you front load with antimicrobial therapy first, you'll likely clear out the SIBO and then have a better introduction of the fiber and the prebiotics if you wait a month or so.
Right. And that's how I like to do it. And also with the fungus as well. I think for me it's kind of a little mind body. So I like treatments to really, as much as possible, be one focal point for the patient to think, okay, I'm killing fungus this month. Let's
Hmm.
killing fungus, instead of saying I'm killing fungus and I'm reestablishing beneficial bacteria. Like I love one variable so that there's just this focus and then what's happening in the gut. So let's just eradicate the fungus, and then now let's focus on rebuilding the microbiome, or the same with SIBO and rebuilding, the microbiome. So maybe I'm simplistic and I like to set up very, very simple focus so it can always be very clear to the mind and the body what we're trying to achieve this month.
Sure. And it certainly makes it a little easier to read cause and effect, right?
Yeah,
Like,
exactly. That's exactly
yeah.
100%. Having the one variable, say at a time, you really know, was this protocol successful?
Yep. Yep. Something I came across recently, which I had never heard of before, it's a protocol to help with the oral microbiome, given that fungal overgrowth in the mouth might seed the rest of the GI tract. I'm not totally convinced that's going to be a massive issue if someone has decent hydrochloric acid production, but it's something I heard about. It's a hypothesis I'm sort of ruminating on. But what this healthcare provider is having people do is use a diluted Dakin's solution, which is essentially a very diluted bleach mouthwash. So it's not bleach, but it's very diluted. And then after that, take a probiotic lozenge and do the Dakin solution once per week, and then follow that with the oral probiotic as a way of sort of cleaning out the oral cavity. My intuition here is that this is probably going to be less effective than more, because there's just so many things that would prevent a little bit of fungal overgrowth in the mouth from seeding the entire GI tract. Your hydrochloric acid, your native levels of commensals, your native immune system. It sounds like we're in agreement, but any thoughts? Yeah.
I don't, it's not something I feel I need to move forward with.
Yeah. Okay. Fair enough. What are some of your favorite herbs? And let me ask you this before we jump in, because there's caprylic acid, horopito, podiarco, cinnamon, olive, garlic. I mean, there's a long list. I'm trying to make up my mind on alcohol-based tinctures. I like the fact that those are very easy to absorb. It's a little easier to throttle someone's dose. Sometimes people are pilled out and they wouldn't mind a different dosing form. And I would like to think that the amount of carrier alcohol is going to be negated by the really powerful bolus of whatever the herb you're administering is, cinnamon, whatever. What are your thoughts on alcohol-based tinctures?
I don't use them with fungus.
You're
That's just an alcohol-free month, and I personally do not use alcohol-based um, tinctures. I love alcohol-based tinctures, mind you, just not with my fungal protocols.
okay. So you're using capsules.
If yeah, I'm using capsules for sure.
Okay. What are some of your favorite herbs or other natural agents for treating fungus?
I mean, yeah, I do. I mean, obviously, caprylic. I mean, first off, if I do a stool test and they do a sensitivity test, that's always helpful. Caprylic acid is a pretty common uh, product that comes up very positive for many. The problem with the horopito, which seems to be an antifungal, but also seems to have some biofilm busting, is that honestly, there's just too many people that it upsets their stomach. I just it's not the minority. It really almost seems really to be the majority. So I've had to really phase that out, even just on one a day. It's just really upsetting a lot of people's gut, and that's unfortunate. But N-acetylcysteine is actually a fairly decent fungicide, but also has some biofilm busting aspects of it. So I like doing that. Of course, there's oregano, as you said, and garlic and berberine and pau d'arco, and olive leaf comes up as well. I also do like, there's a product called, I use from Priority One, Bio Candida Care, that has your rosemary and thyme, which are good essential oils for fungus, also oregano, and then some caprylic acid in it. Combination products. There are many companies that make combination products, and those are all really good to use as well. So, any of these. The problem with undecylenic acid is that the high dose of you need around 900 milligrams a day at least. So it's hard to get that. You're taking a lot of pills if you're just doing with the caprylic acid, maybe 1,000 3 times a day, but that's not that hard. Usually a couple of capsules will get you to 500 or 1,000, and two of those 3 times a day is, I think, an effective dose. So it's just kind of, there's a lot of good variety. If you got a sensitivity testing and can more specifically focus it to that species that they found, that's great. But the sensitivity testing is limited in
Yeah.
what they measure,
Right.
and you really just have to use your experience and what you've seen help patients over the years.
So how about a sample protocol for someone's first month? You'd have them on one of the probiotics. You would have obviously on the diet. How many herbals do you use, and
Well,
what's
I
like a
mean, I'm
general
going to put
dose?
everybody on nystatin. I mean,
Hmm.
that's the
Okay,
key. I'll
that's your
start with
go-to.
nystatin, add in maybe another antifungal like caprylic, with the NAC, say, and the probiotic, right? And the nystatin will be 1,000,000 3 times a day, right? That would be a typical protocol. Nystatin, a supplement for or the Candida Care or caprylic just by itself. Say the
NAC.
probiotic and
Yeah.
the NAC.
Okay. And what percentage, just rough estimate here, would you say this moves a needle for? Is it 50-50? Is it 70% of people?
Yeah, I mean, I would say, 80% of the
Mm,
people, 80 to 90%. If I've, if there was as clear as a diagnosis. On the iffy people, I think it could be maybe, 50-50. But if I saw it in the stool, their Candida questionnaire was at 300, just
Right.
crazy. I'm going to expect around, 90%
Okay.
are feeling
Good.
better for sure.
For the ones that aren't, what do you do second month? You said you may need to go a little bit higher of a dose. So are you just increasing some of the dosages plus I'm assuming adding in a few other agents, or how do you handle that second at bat like I was
Well,
saying earlier?
the second one, I would certainly, so the question is, do I move up to something like itraconazole, one of the azoles, right? I don't really think fluconazole, diflucan, is any better than nystatin, personally. Itraconazole is one of the ones that kills the bud and the hyphae. Um, you can get it really cheap from Cost Plus Drugs, Mark Cuban's pharmacy. It's like 30
Mm,
bucks for a month. It's really cheap.
nice.
But it's a drug, and if and of course the azoles may affect the liver. So I will always give liver support with an azole. I will always give a supplement liver support if I'm moving to that product. I would be changing the antifungal supplement and and then seeing one more month if that could work, if we're going to stay with it, versus moving on and doing some other testing and seeing if, or some other analysis, and just
Right.
seeing, like you said, is there instead something histamine or something else going on that I just misjudged this first month.
Okay. Okay. So again, for our audience, I think if you're quarterbacking your own healthcare, I hope you really heed these pearls because the thing that I find really disheartening is when someone comes in the clinic and they've been treating a given thing for months and months and months or years and seeing little to no response. Um, in gut care, oftentimes we get response, thankfully, pretty quickly. Now, what about relapse? Let's say someone has a benefit and then 6 months or so, a year later, they have a regression. Some of this, just my opinion here, I don't think is that big of a deal, especially let's say maybe they had a child, so they had a period of poor sleep and they kind of started doing a little more alcohol and they just sort of drifted. So I wouldn't say, oh my goodness, there's a major issue here, but rather, okay, this is a little bit of lifestyle associated regression, and we got to do a modified version of what you did before, maybe a little bit lower dose, shorter duration, and you should be able to bounce right back. That's kind of where I go first. But knowing that recurrence can happen, anything in particular that you found effective there?
Yeah, so if someone just goes out and they're doing great, and then, like you said, they went to a wedding, blah, 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 that weekend they just drank a bunch and they have some symptoms, coming back, there's got to be some sort of, maybe they just avoid sugar and alcohol for a month and we do the antifungal, again, and they don't have to do the whole thing, right? As you say. Some patients come back and they just want to do the whole thing in a month and get reestablished, right? So that's just talking with the patient and making a plan that I think is effective and they want to do. The one thing though, like for example, with patients who have Alos Danlos and they get SIBO, like they're always going to get SIBO. I mean, it's going to come back and back. And on those patients, a lot of times I'll just keep them on a rifaximin 200 milligrams a day every day. And in that way, I've had patients who are getting SIBO 4 times a year get SIBO once every 5 years, right? Because we're just saying this is an innate weakness in your body, and this condition has a huge risk of coming back. So let's just stop it every day. You could do, I guess, garlic, a high dose garlic instead if you wanted. But with the people with fungal, if they've had this, like they come to me, they've had symptoms for 5 years. They've had 40 antibiotics in their life. They've had, like honestly, I may keep them on 1 or 2 nystatin a day or 1 or 2 caprylic acid a day, right? Just because Like, I mean, my mom has had macular degeneration, and she's had cataracts. My sister's has cataracts, and one day I got a vitreal tear, right, which is like when your eyeball erupts into fireworks, right? And so I wound up fine, but I'm just thinking, okay, like I don't want macular degeneration. I don't want cataracts. I've already had a vitreal tear. Like my eyes may not be that strong. So I take an eye supplement every day, right? I just take it because that may be a weak point genetically. So for people with their gut, if they either have a condition that makes a recurrence a weak point, or they've just been ill for a long time and just have an innate susceptibility to have this come back again, then just let's just stop it from the get-go, right? Let's just every day just say you need something, an antifungal every day for your gut, right? And so people generally resonate with that, and then they do see. I mean, you have to combine that with this does not give you the allowance to eat like it's Halloween every day and to drink like it's a wedding every day.
Sure.
But patients, they'll listen. And then, so that's another way I can sometimes work in this regard with patients.
Now, what about having someone on a long-term probiotic, prebiotic,
Yeah, yeah,
fiber,
yeah.
and resistant starch, maybe a little sort of smoothie that they make in the morning with all those things?
Oh yeah, I mean those are long term. I apologize. Those are long term anyway, right?
Okay, so
So
that's baked into the
those
cake, so
are
to
yeah.
speak.
So
Okay,
those are long term anyway, just not the antifungals. So oh
gotcha.
yeah, you're correct. I agree with you 100% that way.
Okay. Something I'll just flag also about uh, Ehlers-Danlos is, this is another one of the things that was presented at this year's iLads. Some clinicians are starting to see at least an association between Bartonella, this bacteria that has an affinity for both neurological tissue, but also for connective tissue and Ehlers-Danlos. So something for people, it's just an early clinical observation, and who knows, maybe it'll be disproven with further attention. But knowing that that bacteria really likes collagen and can break down connective tissue, if you have Ehlers-Danlos, maybe something to ask your doctor about doing a blood test to screen for Bartonella. Because to your point, that can be something that's causing the connective tissue in the GI to be weaker and causing this compression on the GI tract and these inflection points where stool slows down, and then you can have bacterial or fungal overgrowth. Um, what about abdominal massage? This is something for constipation, I think is really
Yeah.
interesting. Do you find that for some people, maybe it's either Danlos, maybe it's some other sort of, like they have a lot of tortuousness in their colon and tight turns. And so there's just a need for ongoing pumping to make sure the stool doesn't get stuck and foster a overgrowth of fungus or bacteria. Do you ever integrate this?
Yeah, I mean for sure. And I mean, obviously it's one of the scar tissue in the abdomen is obviously a known etiology for SIBO, for slow migrating motor complex, having, doing visceral manipulation in the gut, a clear passage massage, and so forth. But for the fungus, yeah, I mean, if, just, honestly, on I just, just honestly trying to get them to exercise regularly and get movement in the body, systemically is a good start just to move the blood, calisthenics, just some things along those lines. But anything that moves blood in the body and drains the lymph. And so abdominal massage is fantastic in that regard. Where there's blood flow, I mean, there's just better health. There's less
Yeah.
illness.
Yep.
It's the key of hydrotherapy, key of so many underlying aspects of health.
And to your point, movement of any sort seems to help. Like we say in the
Yeah.
clinic, if you move, your stool moves also. So you might be able to get there with just a good exercise plan.
Right.
What else? I mean, obviously there's a lot here that we can drill into, but is there anything of worth that you think we haven't mentioned yet?
No, I just think that this is. I just think it's good to get this out. I thank you for letting us talk about this, just because I know with, I mean, SIBO is now, I think, for people with gut problems, has really hit a good 100th monkey mark where it's out there and it's known. Even if half of the gastroenterologists still don't believe in it, at least they've heard of it. So,
Right.
but fungal overgrowth is still a little, I think, lagging behind in this regard. And we just need to keep letting patients know that it's a real phenomenon and it's really, unfortunately, pretty common. And it's going to cause a lot of systemic symptoms that people will just struggle through every day.
Sure. Well, this is why if you're listening to this or watching this, and maybe you've been treating SIBO or just doing the general health stuff, but not felt like you've seen the results that you should, think about fungal overgrowth, not limited to Candida albicans, because like we talked about before, there's multiple different species. But yeah, Mona, I think this is a really important area of work. I'm glad that you've been focusing on this for as long as you have. And hopefully this helps anyone out there with maybe muscle pain or brain fog or constipation, loose bowels, whatever it is, get some resolution.
Thank you. Thank you very much.